I'm a urologist from Brussels, Belgium, and I'm very, very honored to welcome you to this ESU online seminar dedicated to metastatic prostate cancer. I know that you may be following us live. In such case, we will be happy to answer your question. But I know also that many of you will be following that in a few days. So I say from the beginning, if you have questions, do not hesitate to contact us afterwards. So I'm not going to do that alone. I'm very privileged to welcome also Dr. Christian Gratzke, a urologist from Freiburg, Germany, and Dr. Constance Thibault, a medical oncologist from Hôpital Européen Georges Pompidou in Paris. So after that short introduction, I'm going to start with metastatic hormone-naïve prostate cancer. Then Constance will address the very controversial and difficult topic of when should we use PARP inhibitor. And then Christian will follow on what should we know about sequencing in metastatic castration-resistant prostate cancer. So without further ado, and we're going to start with the metastatic hormone-naïve prostate cancer, a field that has been dramatically evolving over the next 10 years. So these are my credentials and conflict of interest. As mentioned, I'm a urologist from Brussels. I also do a lot of clinical trial, mainly through the European Organization of Research and Treatment of Cancer. As such, I'm an investigator and advisor for many companies, but I trust you that presentation reflects my personal view. So I think that it started with Chris Sweeney and Karim Fizazi looking at the benefit of docetaxel like 10, 15 years ago. But I think that after the publication of two trials, I'm going to show you, Piece 1 and Arescence, we have come to what I call maximal androgen blockade. I mean, urologists like myself, we remember speaking about combining androgen deprivation therapy and bicalutamide and all of that. And I think that no, the wheel has turned, and we've come back to the point that we can say that the standard of care for any metastatic hormone-naive prostate cancer is ADT plus one of the AR pathway inhibitor, and this irrespective of the timing of metastasis, the volume, risk, burden, and the co-administration of docetaxel and radiotherapy. And we're going to go in detail to this. Indeed, we have a very large number of patients, more than 10,000 patients who've been doing in close to 10 trials, all randomizing androgen deprivation therapy versus androgen deprivation therapy plus X. As mentioned, it started with docetaxel, then abiraterone, then apalutamide, enzalutamide, darolutamide with docetaxel, and two trials, plus a third one we usually don't mention, which is the ORAT radiotherapy, looking at adding prostate radiotherapy. There was still a discussion in the guidelines, is that one of the problems is that we always would discuss docetaxel versus one of these hormones. In many countries, it was, docetaxel was cheaper, these drugs were not available, and every single MDT, we would be discussing, are we going to go for chemotherapy? Are we going to go for one of the hormones? So that's a long history. And it was reflected in the guidelines, because actually the guidelines would say that you should not use androgen deprivation therapy alone, that you should recommend either chemotherapy, notwithstanding the volume, or ARPI and ARPA, or radiotherapy. So that our question was indeed, enzalutamide and apalutamide were the one we tested in low volume. You remember that abiraterone, the STAMPEDE, and the Latitude trial was done in a high-risk patient. The STAMPEDE trial was not a registration trial, so the company never had a specific market authorization in high volume. And it's only Arches, Enzamet, and Titan who have looked at the benefit of enzalutamide and apalutamide in low volume disease. And they see that actually this is Arches, and it's actually even better in the low volume. This is the Titan, the apalutamide. So clearly, we know now that ADT plus an AR pathway inhibitor works very well, high, low volume, and this has become the standard of care. But at some point we say, okay, we need to work on that, or is it maybe that we should not choose, maybe we should combine? So we decided almost close to 10 years ago, no, 2014, we designed actually 2 trials, not to say what is the value of the triplet, because the question we have many times, but to address that question, is ADT plus docetaxel alone a good option? Is it allowed to do that because it's cheap, or no, even if you use docetaxel, you should add an hormone therapy? And 2 trials were planned. The first one was started by Karim Fizazi. It's the Peace-1 trial, a Unicancer trial. Actually, it started by enrolling patients with or without docetaxel. But in 2017, the steering committee realized that there was a trend to have ADT plus docetaxel as a standard of care, especially in high-risk patients. So they made it ADT plus docetaxel mandatory, so that it's a large continuous group of patients who have received ADT plus docetaxel, and then randomized ARPI plus radiotherapy, ADT alone, or ADT plus radiotherapy. This is the result of the ARPI arm. So you see that it's very significantly increased overall survival in the overall population, and also in the ADT docetaxel population, the hazard ratio being even actually 10% lower in the ADT plus docetaxel population. So after Peace-1, we could say, if you have abiraterone available, if you select the patient for ADT plus docetaxel, you should receive abiraterone also. A little bit later, we started planning the trial in 2015 with Bayer. We did the similar trial, ADT plus docetaxel, very simple, broad trial. It was not yet mentioned about high volume, low volume. So we went for a simple definition, M1A, M1B, M1C, randomized darolutamide, 6 milligram BID versus placebo, same observation, major benefit in overall survival, hazard ratio more than 30%. We try now to look at what it means for the patient. If you say a patient, for instance, if you look at 4 years, what is the likelihood you're going to be alive if you receive only ADT plus docetaxel? It would be something like 50%, and you add another 12%, which is very significant if you combine upfront with darolutamide. And for both drugs, I show here the darolutamide. Still, you have some toxicity of docetaxel, which is actually acceptable. And what is very interesting with abiraterone and darolutamide, it does not increase the toxicity of docetaxel very significantly. So you can still give your 6 cycle of docetaxel very safely. There will be no increase in the toxicity. It seems easy to say that, but keep in mind that before that, we had done more than 30 trials in metastatic castration-resistant prostate cancer, trying to combine docetaxel to something, and consistently it had failed. And that's interesting that technically the other trial will look at the combination of docetaxel plus an AR pathway inhibitor were not that successful. In Arches and Titan, it was tested sequentially, meaning that it was ADT plus docetaxel followed by ENZA or APA. And in the ENZAMET trial, the benefit is still barely significant. One of the reasons may be drug-drug interaction. This is a study by Mike Morris looking at the circulating concentration of docetaxel when it's combined with enzalutamide. And you see that enzalutamide does decrease the concentration of docetaxel. So is it the reason why we show this result? We don't know really. So based on this, the guidelines have been changed. And you see that no, they recommend double combination ARPI, APA, ENZA for low volume, high volume. They don't mention docetaxel link uniquely to high volume, and that's interesting. We will discuss that later on. They still discuss the possibility of doing only upfront EBRT, and we're going to see what it become after Peace-1. And you see that when you do a triple combination, it has to be with darolutamide or abiraterone. So what about that link? That link comes from the STAMPEDE trial. The overall trial was negative. Adding radiotherapy on top of ADT didn't change the fate of patients with metastatic hormone-naïve prostate cancer. However, if you focus on the subgroup of patients with low volume, there is a very big interaction that say that in the low volume patient, there is a benefit of radiotherapy. And because of that, it has been incorporated in the guideline and considered as a standard of care. However, no, we may have to reconsider this position again, since Alberto Bossi reported at ASCO GU this year the result of PIS-1 radiotherapy arm. And you see that in the PIS-1, even in the low volume population, whether or not the patient has received abiraterone or not, radiotherapy doesn't increase overall survival. One of the explanations being probably that the overall survival in PIS-1 is extremely long, probably reflecting very high level of oncological care in France. So that today the question is different. The question today is not, is it radiotherapy or hormone therapy? The question today is, it should be ADT plus one of the AR pathway inhibitor for everybody. And we have other question. Which AR pathway inhibitor? Very difficult question. You know, they are all very active. When you look at the proportion of patients who stop the drug, it's very minimal. So they are extremely well tolerated. Abiraterone may be a little bit less inconvenient. You need to combine it with prednisone. You have to give it with food. Toxicity is quite acceptable, hypertension, hyperkalemia. As for the AR pathway inhibitor, APA and darolutamide, the advantage is the fact that they're easily administered. They're very easy to monitor. There is no co-administration with prednisone. There is a lot of discussion from the company, which one is less toxic, which one has more this and this. I think that as physician, you should make your own choice. And I would like to show you that beautiful paper produced by the FDA, who actually look not only at the median reported value, but more importantly at the 95% confidence interval of reported adverse event. And they report that it's extremely broad. And their conclusion is that actually you cannot make any difference between the AR pathway inhibitor based on the three registration trial. We need specific trial for this, or you have to make your own experience. So should not stop. This is different. Something that may be different and important is drug-drug interaction. All these drugs may interfere with a different type of agent. So in the end, it may be your pharmacist which is helping you. So at this point in time, they have all demonstrated similar efficacy. There is no head-to-head comparison to claim that one is better tolerated. We need chemotherapy at this point in time. This is a difficult question. We don't really have data to answer that question. We have meta-analysis pointing at the fact that patients with high volume disease may be more candidate for a chemotherapy, and patient with an aggressive phenotype. It's an ongoing question. It's very difficult to answer. Finally, we need radiotherapy. I think that after PIS-1 doesn't kill the radiotherapy. PIS-1 shows something very interesting that we supported for a year, is that radiotherapy may actually impact very significantly the time to serious genitourinary system even. A problem we know, urologist, is a real problem. JJ stent, transurethral resection, and actually what they show is a very significant effect on genitourinary toxicity. So in conclusion, I think that for metastatic hormone-naive prostate cancer, the standard of care is ADT plus AR pathway inhibitor. There is no, I think, no role for ADT plus docetaxel alone, and I believe there is no role for RT alone either. They are all very similar. Try one, make your own choice. Don't listen too much to what you heard. Look at the data, look at your own patient. I really believe high volume patient may benefit from chemotherapy. Who need radiotherapy? I think that it's not going to be given to increase overall survival, but to delay complications. So thank you very much for your attention for that first presentation. Having said that, I will now hand over to Dr. Constance Thibault, who's going to give us a little bit more about PARP inhibitor.
So good evening, everybody. The objective for the next 15 minutes is to provide you an update on the available data regarding the efficacy of PARP inhibitor when used in combination with androgen receptor pathway inhibitors in mCRPC. So over the last decade, we have gained substantial insight into the pathways involved in the oncogenesis of metastatic prostate cancer. For the majority of patients, AR pathway plays a pivotal role in the development of this cancer, but it's not the only one. The DNA repair pathway also holds a key role, and approximately 25% of mCRPC patients exhibit mutations in genes involved in DNA repair pathways, particularly in homologous recombination repair. The most commonly alterated genes are BRCA2, which affects nearly half of HR patients mutated, ATM, CHEK2, and BRCA1. And in half of cases, it's a somatic mutation, so the alteration is confined to the tumor, while in the other half, it's a germline mutation. So this led to a rationale for assessing the efficacy of PARP inhibitor as a monotherapy. And as you are aware, the mechanism of action of PARP inhibitor is based on synthetic lethality. There are several pathways capable of repairing DNA repair. PARP and BRCA play roles in two different pathways. And should one pathway fail, another step in. However, inhibiting a pathway with a PARP inhibitor in the presence of a BRCA deficiency prevents DNA repair and leads to cell death. Subsequently, the PROfound trial was conducted to evaluate the efficacy of olaparib as a monotherapy in patients with mCRPC who had previously received at least one ARPI and who had HRR mutation. And a clear benefit was observed in patients with BRCA mutations, both in terms of RPFS and OS, despite the crossover, and even though the OS was a secondary endpoint. Conversely, no benefit was observed in the cohort of patients with other HRR mutations. And based on this finding, olaparib received an approval from EMA for patients with BRCA mutation, but the FDA gave a broader approval for patients with HRR mutation. And recently, preclinical studies conducted on cell lines and xenograft models suggest that PARP also plays a role in the AR pathway, and the AR plays a role in homologous recombination repair. As you know, AR is an intracellular receptor and serves as a transcription factor for several genes implicated in oncogenesis, and PARP acts as a co-regulator of AR, facilitating its transcriptional activity. Therefore, the hypothesis is that a PARP inhibitor may also decrease the transcription of genes regulated by AR. And on the other hand, AR is also a transcription factor for genes involved in homologous recombination repair. And consequently, with a PARP inhibitor, we induce a deficiency in HRR, creating an HRR deficient-like phenotype, thereby enhancing the effectiveness of a PARP inhibitor. So PARP inhibitor monotherapy should have theoretically activity only in HR patients, but PARP inhibitor in combination with ARPI might have anti-tumor activity in HR positive, but also in HRR negative, but it was a theory. Having said that, 3 randomized phase 3 trials have been conducted to evaluate the efficacy of a PARP inhibitor in combination with an ARPI as first-line treatment in mCRPC. PROPEL with abiraterone in combination with olaparib, Magnitude with abiraterone and niraparib, and TALAPRO-2 with enzalutamide and talazoparib. And as you can see on the slide, the design of those 3 trials was a bit different. In PROPEL, the HRR status was performed retrospectively after randomization. In MAGNITUDE, it was performed before randomization, and depending on the results, patients were enrolled in cohort HR positive or HRR negative. And in TALAPRO-2, the HRR status was also performed before randomization, and cohort 1 comprised all comers patients, so patients considered as HRR positive, but also HRR negative or unknown, and cohort 2, only patients HRR positive. And the primary endpoint of those 3 trials was RPFS. OS was just a secondary endpoint. And before summarizing you the results, I want to stress the population of patients enrolled in those 3 trials. Only 20% were previously treated with docetaxel and less than 6% with ARPI. Whereas, as Bertrand said just before, the vast majority of the patients in 2023 are treated with ADT plus ARPI with or without docetaxel at MHSPC. So the patients included in these 3 trials do not accurately represent the patients' population we will treat in the coming years. These 3 trials were positive, demonstrating an RPFS benefit in favor of ARPI and PARP inhibitor for all patients in PROPEL trial and TALAPRO-2 trial, but only in HR positive cohort in the MAGNITUDE trial. Indeed, the HR negative cohort of MAGNITUDE trial was terminated early due to futility after enrolling approximately 200 patients. So this slide presents the RPFS curves of patients in each arm. On the top of the slide, it's the curve of all patients enrolled. In the middle of the slide, it's the curve of HR positive patients. And in the bottom of the curves, the BRCA mutated patients. And as you can see, the separation of the curves is more pronounced for BRCA patients compared to HR positive and to all comers patients across all trials, because BRCA mutated patients derive greater benefit from the addition of a PARP inhibitor. Another noteworthy observation is the control arm curves. It is apparent that the median PFS is clearly shorter for BRCA patients compared to non-BRCA patients. This underscores the poor prognosis associated with BRCA mutations and the shorter response to ARPI compared to non-BRCA patients. Moving on, the RPFS curves for HR negative patients, data are available from PROPEL and TALAPRO-2 trials. While there is a statistically significant difference, it is less substantial than in HR positive and BRCA patients. And in terms of OS, we currently have mature data only from the PROPEL and the MAGNITUDE trials. In PROPEL, there was a trend favoring a combination therapy with an absolute difference of 5 months, though it did not reach statistical significance. However, a statistically significant OS benefit was reported for HR positive patients in PROPEL and BRCA patients in MAGNITUDE. What about safety? PARP inhibitors share similar adverse events, particularly hematological toxicity, including anemia, neutropenia, and thrombocytopenia. Other commonly reported adverse events include fatigue and nausea. Notably, in the PROPEL trial, almost half of the patients experienced treatment interruption due to adverse events, and 20% underwent dose reduction and 15% discontinued olaparib due to adverse events. And the rates of dose interruption, reduction, or discontinuation were very similar in the MAGNITUDE trial. But in the TALAPRO-2 trial, the rates were a bit higher. As you can see, 75% experienced interruption, and over half had a dose reduction. And the primary reason was hematological toxicity, particularly anemia, which affects 2/3 of patients, with a grade 3 anemia observed in 43% of patients. And remember that the definition of a grade 3 anemia is an hemoglobin level below 8, and typically it necessitates a blood transfusion. And just a brief mention on quality of life. Despite the increased incidence of adverse events in the combo arm, we did not observe a deterioration in terms of quality of life. So to summarize the data from these trials, there is a major RPFS and OS benefit for BRCA patients. There is also an RPFS benefit for all patients, regardless of HR status, but no OS benefits. The addition of a PARP inhibitor induces additional toxicity, particularly hematological adverse events, whereas an ARPI is very, very well tolerated, but these adverse events usually occur during the initial months of treatment, up to 3 to 6 months after initiation, and tend to decrease over time. So in 2023, combination of PARP inhibitor and ARPI have received approval in both Europe and the US, but indication differ depending on the drugs and the population. In Europe, abiraterone and olaparib are approved for all patients, whereas abiraterone and niraparib is only approved for BRCA patients. But in the US, abiraterone and olaparib and abiraterone and niraparib are approved exclusively for BRCA patients, and enza and talazoparib is approved only for HR positive patients in the US. And surprisingly, the approval did not specify whether patients previously treated with ARPI are eligible for this combination. However, in my opinion, there is absolutely no rationale or data supporting the efficacy of ARPI and PARP inhibitor in patients previously treated with ARPI at MHSPC stage. So in clinical practice, the key question is who should receive the combination of PARP and ARPI at mCRPC stage? Well, I think that we must assess the benefit-risk balance, considering potential adverse events and the cost of PARP inhibitor weighted against the anticipated benefits, which may vary between BRCA patients and patients without any HR alteration. And consequently, I think that genetic testing remain mandatory, because we won't manage a patient with a BRCA mutation the same manner that we manage a patient without a BRCA mutation.
And thank you for that very nice summary. And I'm now going to hand it over to Christian Gratzke for the metastatic CRPC part.
So thank you very much, and thank you for inviting me to present on mCRPC. You have heard about the PARP inhibitors, and I will try to cover the sequence and what's also important in the mCRPC space in the next coming 15 minutes. Here are my conflicts of interest. So this is the treatment landscape in 23, starting from NMCRPC to MHSPC to mCRPC. You've heard from Dr. Tombal about MHSPC. And I will try to start summarizing new data on NMCRPC in the beginning. You're all aware of the 3 pivotal trials leading to approval of 3 different drugs for NMCRPC, and I won't go into detail. But the one question we will have to answer and discuss is the question about imaging and PSMA PET imaging, so modern imaging. That's the pivotal trial that was published by Wolfgang Fendler and the Essen group, showing that if you use modern imaging in all of the NMCRPC trials, where only conventional imaging was done, in almost all of the patients, you will detect metastases, showing that you shift patients from NMCRPC to an M1 disease. Whether this relates and translates to a biological relevance and improved overall survival, I think at this stage is unclear. But given this background, I think the one trial that showed new data on NMCRPC patients. It's a DEER trial that was published by Dr. Dan George, and presented by Alicia Morgans. It's about real-world use of darolutamide, enzalutamide, and apalutamide for NMCRPC. And this is a retrospective observational chart review using electronic medical records from US urology practices. That's something we have to keep in mind. And if you look at the left graph, you'll see that this trial was done from 2019 to 2022. And over those years, it becomes apparent then, while at the beginning, enzalutamide was the drug that was used most often, this shifted towards darolutamide in 22. And if you look on the right side, you see that the discontinuation and progression rates to MCRPC were the lowest for darolutamide in comparison to enzalutamide and apalutamide. What's also important is that, of course, comparing, and that might be a stratification factor for you, compare adverse events, progression to MCRPC or death, switch to another ARPI, cost reimbursement factors. Overall, there is a very homogeneous picture where darolutamide receives the least adverse events and has the lowest rates of progressing to MCRPC or leading to death. And that might be one stratification factor. As Bertrand Tombal has said it, there are pros and cons for every drug, but those are the newest data that we have on NMCRPC, which I would like and wanted to share with you. So let's continue to MCRPC, and the one topic that received, I think, most attention over the last meetings was radioligand treatments next to PARP inhibition, which you just heard from Constance. And radioligand treatment using lutetium-177 PSMA imaging has been shown first using the VISION trial, which I will not allude to, but I would like to more focus on the PSMA-4 trial, which some of you might have seen at ESMO, presented by Dr. Oliver Sartor. It was a phase 3 trial using lutetium PSMA treatment in taxane-naive patients with metastatic castration-resistant prostate cancer. And that trial included patients with confirmed progressive MCRPC that had at least one PSMA-positive metastatic lesion on PET scan, and that had progressed once on a prior second-generation ARPI. Those patients, as I said before, were taxane naive. So the patients were randomized to receiving radioligand treatment, lutetium PSMA, versus change in ARPI. And that might be something that you would like to criticize or discuss later on, because at least in our practice, usually you don't sequence one ARPI to the next one once the first ARPI actually has failed, but you try to use a different mode of action. But that was the trial design in the PSMA-4 trial. What's also important is the fact that crossover was allowed upon radiographic progression by central review. Now, the primary endpoint was RPFS, and the key secondary endpoint was overall survival. We have a list of other secondary endpoints, which you see here in the list. What we were shown at ESMO was the updated second interim analysis. Patient baseline characteristics are shown here. What's important is the fact that almost 90% did have bone metastases, around 1/3 lymph node metastases, and around 5% and 3% respectively had liver metastases. This is the primary endpoint, which was met, which was RPFS, and you see how the curves and when the curves separate. You see that the updated hazard ratio was 0.43, so a very clear result. When you look at the subgroup analysis, it is also evident that most of the horizontal bars are to the left of the vertical bar, showing that there is a very consistent efficacy with regard to a trend, with regard to a better result using radioligand treatment versus ARPI change. The second interim overall survival analysis showed that with a hazard ratio of 0.8, there was no significant difference here with regard to OS, But you have to keep in mind that the crossover rate, as shown here, was 84.2%. That's what we have to discuss later. Question is, can you expect a change in overall survival given this very high crossover rate? The treatment emergent adverse events are shown here. You had 20% serious adverse events with lutetium PSMA and 28 with ARPI change, leading to dose adjustment in 3% and in 15% of cases, respectively. So the PSMA-4 trial concluded that PSMA radioligand treatment prolonged rPFS versus ARPI change. The secondary and exploratory endpoints also favored lutetium PSMA treatment with regard to PSA response, objective response rate, time to symptomatic skeletal events, time to worsening in quality of life and pain, and the pre-specified crossover adjusted overall survival did have a favorable trend, but was not significantly different. The side effects were manageable and did not show any new signs on top of what we already knew with both treatments. So we can discuss the PSMA-4 trial later, but there are other aspects in the mCRPC stage which I think are most worth mentioning. And I would like to pick up the ARTO trial because this is a trial which I think we do in clinical practice a lot, but don't have much evidence. And so what is this trial about? It's about using stereotactic radiation therapy, which I abbreviate with SBRT, to ablate metastatic foci that may improve clinical outcomes in the oligometastatic setting. And you know, oligometastatic, defined as anywhere between 3 and 5. It's a bit arbitrary, but in that patient cohort, SBRT was tested on top of an ARPI, which here in this trial was abbreviated with the word ARTA. So patients with mCRPC and maximum of 3 lesions were enrolled, no visceral lesions, no previous therapies for mCRPC, and they were randomized into arm A, which was the control arm, abiraterone, and arm B, which on top of systemic treatment received SBRT on all metastatic sites of disease. The primary endpoint of the trial was the biochemical response rate, but they also looked at complete biochemical responses as a secondary endpoint. The study population is shown here. 50 to 60% of patients had bone metastases, and around 49 and 40% respectively had nodal disease only. This is the result, and as you can see, the biochemical response did differ between the groups. Also, the complete biochemical response, when you look at the blue curves and the blue graph, there was an increase when using SBRT. And that was the first analysis that was shown here. So that first analysis concluded that a promising efficacy of SBRT in combination with abiraterone in a patient cohort with oligometastatic disease, and also that the baseline burden of disease seems to predict the increased outcome after SBRT. And now, only 2 months ago, the trial was published, a bit more patients, and you can see that the biochemical response and the complete response rate differed significantly between the arms. So the conclusion of this trial was that yes, SBRT does yield to a significant rPFS improvement. I think it's an important message, keeping in mind that we all do this and we aim at improving survival, but we weren't shown data that it actually does. My last topic is what actually happened to IO pembrolizumab, and the ASMO showed 2 trials. We already had seen 2 negative trials using various combinations with olaparib and docetaxel. This was here done in combination with enzalutamide, and I presented one of those trials, the 991 trial, Keynote 991, using pembro plus enzalutamide and ADT, and that was in MHSPC patients. So this trial enrolled patients with confirmed MHSPC and at least 2 bone lesions or visceral disease, no prior NHA therapy, and they were randomized into receiving pembrolizumab in addition to enzalutamide and ADT versus enzalutamide and ADT and placebo. They looked at prior docetaxel use for MHSPC and high volume disease and stratification factors, and the primary endpoints were RPFS and overall survival. And that was the RPFS, the primary endpoint. As you can tell, no significant difference, hazard ratio of 1.2. And if you look at the subset analysis, you see that there's even a significant favor of the control group in patients with prior docetaxel use and high volume disease. So no additional benefit when adding pembrolizumab to enzalutamide and ADT, unfortunately. Here are the overall survival rates. The curves almost overlap. Hazard ratio here is 1.16. And also the subs analysis forest plot did not show any significant differences. Yet, with regard to safety, there is a difference because the addition of pembro does lead to a greater prevalence of side effects, any grade, any cause, adverse events, also of course immune-mediated adverse events and infusion reactions. On the right side, you see the side effects of interest with fatigue, arthralgia, rash, and diarrhea being the one with the highest prevalence, ranging somewhere between 20 and 31% of cases and of patients. So additional side effects, but no clinical benefit for our patients. So no reason to actually administer pembrolizumab to any patients in any stage at the moment. So I think we can conclude that the strategy that we used in the MHSPC stage determines the sequence. And there is little evidence for the best management and the best sequence, and we need biomarkers. We always say this. And because we say this, I have one slide showing that we do have biomarkers. We use them. We use PSMA positivity. We use HRR mutations. We use PTEN deficiency. That might also be easier by testing because you use immunohistochemistry. We also do studies that don't include biomarkers. Cyclone is one of them, abemaciclib, CDK4/6 inhibitor. The Keynote 991 trial I just presented, maybe there was a mistake. We should have used biomarkers like CDK12, TMB high, MSI high, but of course, as you know, if you add this up, maybe 12–15% of patients would have these biomarkers. And now we have to go back and look at the responders, because there are responders, and find out who these patients are and who these patients are to actually respond to pembrolizumab, which we don't know at this moment. Thank you very much for your attention.
We have like 10–15 minutes. We have a little 10 minutes, so I have a few questions. So Constance, there is a difference between treating without knowing and treating a negative patient. What is your position of this? I heard a few weeks ago somebody proposing, okay, I think that's what you do in Germany, Christian. You start the treatment and then you reassess the use of the combination once you've got the result of the testing. What's your position on that, Florence? Constance, sorry.
No problem. I think that usually there is no rush starting the treatment at mCRPC stage. Of course, sometimes we need to start the treatment very quickly when the patient is symptomatic. And personally, I try to do the test of BRCA mutation earlier in the disease, as soon as the patient has metastases. I do the test so I can decide which treatment I'm going to prescribe and to think about the sequence of treatments. So personally, I prefer not starting a PARP inhibitor without knowing if the patients have or have not a BRCA or an HR alteration, except in the rare cases where we need to start the treatment very quickly. And probably in that case, I'd rather use the combo and maybe decide to stop the PARP inhibitor if the patient doesn't have an alteration.
Thank you. Christian, and there are a lot of questions about new imaging technology, as you may guess. I mean, do you think that we should use PSMA imaging more systematically in patients on metastatic CRPC?
So I think there are two indications where in the perfect world we would like to use modern imaging using PET scans, using PSMA PET scans, which is a high-risk patients at first diagnosis. So the staging for a high-risk patient with prostate cancer, I think here modern imaging might make sense, because here every other treatment modality that follows is depending on this treatment. So here, yes, I think it is worth it. And also when changing treatments during the course of mCRPC. This topic about NMCRPC, of course, is an interesting one, because as I showed, most patients using conventional imaging would have had metastases using PSMA PET scans. Some would say, well, you don't need it because you can actually use those 3 drugs and they work well. You have the MFS data. And some will say, well, using PET scans showing metastases, you can actually apply what also showed stereotactic radiation if there are bone metastases. And I don't believe that we have a convincing result and an answer for this. I think the trial that I showed on stereotactic ablation is a nice one, showing a good efficacy using stereotactic radiation on metastases, predominantly bone.
Thank you. I'm going to switch now back to the metastatic hormone-naïve and ask you a question I have. What is your personal view, Constance? When do you recommend chemotherapy, docetaxel? What is your typical patient and your less typical patient?
I prefer to use the triplet for patients with de novo MHSPC with a high volume and who can tolerate chemo, of course. And I personally do not use docetaxel in patients with metachrome MHSPC or with low volume. I prefer to use ADT plus an ARPI.
I can confirm very much Constance's view. The one patient cohort I never use it is metachrome low volume. But in everybody else, I would use it. We have a very high tendency towards using triplet treatment here in Germany. It also allows us to use, and that's very interesting, because when you discuss what follows triplet treatment in the first-line mCRPC stage, here you are with no little evidence what to use. But if you use, of course, my personal opinion is that you have a fairly young patient that is high volume. You would like to use several mode of actions to give the best treatment strategy that you have, because I personally believe that prolonging the occurrence of mCRPC is the most important part that we have. Because once the patient is castration resistant, you do all the strategies that you have, but sort of the deal is done. But prolonging MHSPC stage for as long as you can brings a real clinical benefit for the patient. That's my personal belief. And therefore, intensifying treatment at the beginning for me is important.
And on the other part of the spectrum, have you changed your view on local treatment after piece 1?
Well, I was a bit surprised of the lack of OS benefit observed in piece 1. I'm a bit also skeptical about, the benefits on urological complication, because if you look at the type of complication, it's not major ones. So, however, as it seems that it may prolong the RPFS and delay the chemo, I think that I will continue to think about radiotherapy on the prostate in patients with low volume, even though I prescribe ADT plus an ARPI, even there is no OS benefit, because I think that delaying the chemo and prolonging the MHSPC stage, as Christian said, is a clinical meaningful endpoint.
And Christian, to you, then I'm going to switch it a little bit, is that as long as we were focusing on overall survival, we had absolutely no data for surgery. But now that we speak about local control, is it not giving also a different twist for surgery?
Where I got my training in Munich, we did metastatic, patients. We did radical surgery on them for many years before it was really a big topic. But we realized that in patients with high volume disease, of course, this was not not a good idea at all. And now we follow the guidelines very much. We don't do surgery on metastatic patients, but I send them to radiotherapy. I won't send patients with high volume disease for radiotherapy because Alberto Bossi was concluding in the Peace 1 trial presentation that selected patients with high volume disease can be sent to radiotherapy. I'm not totally convinced just by the biology of the disease, but in low volume disease, I do. But I do also intensify systemic treatment. It all also comes down to the conversation with the patient because not every patient is different. I think we need to take into consideration, of course, comorbidities, age of the patient, the expectations, the wishes. I can reiterate what Constance said about whether we define those complications as serious, because again, I also don't think those are actually serious adverse events. They are very common adverse events, and so I do, like in oligometastatic patients, I send them for radiotherapy, yes.
Yeah, because we tend to forget that when we look at the result of STAMPEDE and made a claim on OS, it's because the interaction test was very significant. A very significant interaction test means also that there is an interaction also between high volume and radiotherapy that goes the other way around. If you look at the result of STAMPEDE, there is a trend toward an inferior overall survival when you give radiotherapy to these patients. So I agree that we really need really robust evidence before we start treating everybody.
So the one, just a short remark, when you look at STAMPEDE trials, they use conventional imaging, bone scans. Again, the SN and UCLA group showed that conventional imaging using bone scans in M1 oligometastatic disease, they showed this at ASCO this year. If you use here PSMA PET scan, those M1, maybe 2 or 3 lesions ended up not having any metastatic lesions at all anymore, which is giving you food for thought because those patients might actually have been M0 patients. And of course, radiotherapy is then, leading to a significant overall survival. That's my idea behind that.
And then a last question for both of you, and maybe, do you think that we're treating patients too long? Meaning, do you believe that, no, we have this huge response, there is opportunity to revisit strategies such as intermittent androgen deprivation therapy in these patients, in clinical trial, I'm speaking. Constance?
So I start first. I totally agree. I think that now we don't have good biomarker to identify patients that might benefit from de-intensification. We know that PSA level at 9 months for MHSPC patients is a good prognostic factor, but it's probably not the only one, maybe ctDNA or other biomarkers. But I think there is a real need to think about this de-escalation. Personally, I don't do it in clinical practice outside a clinical trial, but there is this is a key question, and you Bertrand are leading an ORTC trial raising this question.
Christian, last question for you. In my presentation, I failed to mention a very important trial with immunotherapy in metastatic hormone sensitive. Unfortunately, it's not very positive. Do you think we should keep trying, or is your conclusion that it's definitively not a target for IO agent?
So the leaders in the field like you, but also Johan de Bono, they always say we have patients that are on Pembro and they have very good results for a number of years. Now we have 4 negative phase 3 trials. I think we need to acknowledge that for all common population, it just doesn't make sense. It doesn't work. And it's not the only entity where it doesn't work. If you look, for example, at ovarian cancer. But I would say that now we have 5,000 patients in those phase 3 trials. The one important remark I would have to say is that in the study that I was involved in, the control group did receive enzalutamide, which was at the time the best control treatment that we could actually offer. And that trial was done in many countries where enzalutamide was not available. So for those patients, it would actually a big clinical benefit. I think we need to go back now and analyze those 5,000 patients and see who the responders are and look at the biomarkers that we have, like I said, CDK12, MSI high, TMB, and maybe find a red string among those patients, and then finding out if there are patients, and if there are any, who these patients are that benefit from pembrolizumab.
Thank you of this great work of strategy and future. I would like to close this seminar. Thank you very much for you too, and for everybody that attended. To remind you that it has been recorded. It will going to be available on YouTube channel within 48 hours. Please send it to your collaborator. There will be also CME point available. Having said that, wherever you are, I wish you a very good end of the